Unlike Vietnam, we are not in a period of quiescence. There are ongoing struggles, short of major combat operations globally. So I'd like to talk a little bit about where the Joint Staff comes in. We have a national security strategy that the President has put out that we're working off of. And there's a national military strategy which by a law is mandated for the chairman to publish to set priorities, readiness priorities, and the focus for the force for the near future, 10 years out generally. The current NMS is ready to be signed out, but let me just talk about what we have in publication rather than to talk about pre-decisional publications that we have going on. So we have the capstone concept for joint operations. We have the Joint Operational Environment 2035, and we have the Joint Concept for Health Services, are three documents that I want to talk about briefly. The capstone concept for joint operations, in essence, speaks about globally integrated operations. And so you've heard General West talk about that aspect. That's the part I'm saying that is, she is nested, what she's offered for Army medicine under the Joint Staff strategies and concepts. Within a globally integrated operation, you want to have an agile, innovative, small footprint force. You look at the Joint Operational Environment 2035, the major concept that comes out of that is the future security environment is a TMM environment. It is trans-regional, it is multi-domain, and multifunctional. There is the focus anymore is not on what does a combatant command want for its region. The Joint Staff steps back from that and says it is going to bleed out outside of your region. And the Joint Staff, in support of the chairman, must address those issues. So we are not moving towards addressing GCC issues in a vacuum without knowing that it impacts other areas. Multi-domain, heretofore we've talked about air, land, sea, space. Add to that now cyber, and add to that as well human. And there's going to be multiple domains. And if nothing else, there's going to be a cyber component to any conflict that automatically makes it global. So you can see the complexity of all those things. And then finally, multifunctional. And there in the line, they'll talk about whether it's missile defense or ground operations. But the way I think about it from a medical standpoint, you may be doing one thing one day, and on a dime be asked to do something different the next day. On one day, you may be doing medical, civil, military operations. Next day, we may ask you to support contingency, surgical support for major combat operations. So what I've seen, so with those in mind, the Joint Concept for Health Services was written. In essence, to encapsulate it in a word or two is globally integrated health services. It must be agile, it requires partnership, innovative, small footprint, working together in support of whatever's going on. There's going to be a full spectrum of competition with the United States, not only overt major combat operations, but it could be at any level, and we have to be prepared to operate in any of those realms. And one of the things that we're facing now that you heard about on this film is countering violent extremist organizations, and that is a global fight, and the Americans are involved across the board. So something that I recognize, as General West recognized, which is a Joint Staff Surgeon, was in the Africa area of responsibility. There are a number of organizations out there that we are countering. And to put it in perspective for you all, and the way I think about when medical is involved or requested to support, we don't support by volume, we support by geography. So all you need is one American at risk, and that could generate a requirement for medical contingency support. And the the demand, quite frankly, can very easily outstrip the supply that Army doctrine, Air Force doctrine, and Navy doctrine has set up to support that has been successful in OIF and OEF. And just to give you a visual picture, imagine if you had a 6-person team in Manhattan and you had another 6-person team in Palo Alto, and they're asking where you want to put the medical footprint to support those 2 entities. So that's the kind of distances you're talking about in support of AFRICOM efforts. So we have to get after some innovative ways to address what the warfighter's asking, right? So when the warfighter asks, when they have this itch, what I'm hoping for the Army, Navy, and Air Force is to be able to address that itch in a way that is meaningful to them, rather than to explain to them why it can't be done. And I applaud General West for the work that she's done thus far. What I'm looking for is a sustainable solution set among the services so that we can get after that. And if we use the AFRICOM model that I just painted, and keeping in mind globally integrated operations, agility, small footprint, innovative partnering organizations, and this TMM environment, I'm hoping that now we can use our panel expertise to discuss ways that we can think about addressing, within Army medicine, addressing this challenge that faces us. Thank you.
Thank you, sir. We're going to go into question and answers, so if those that want to fill out their cards, we do have some initial questions to go on, but we do encourage the audience to fill out the cards. I'm going to start out with the first question directed to Colonel Czarnik, and especially given what we saw on the screen. How has the Army medicine adapted to overcome the tyranny of distance seen in places like Africa when given the absence of the golden hour medevac we enjoyed in CENTCOM?
Sir, thank you very much. I just want to start out by saying, ma'am, thank you very much for the work that you've done. You know that the only reason I stay on active duty is because we worry about that soldier at the end, and you stepped up to the plate there. You didn't think medical operations, because there's no such thing as medical operations. There's just operations. You thought about the support to the warfighter, and you did it. You moved me to tears because you made it happen. Thank you. I just want to say that from the get-go. Let's talk about Africa. Yes, I am the U.S. medical liaison to the U.K. right now, but before that I spent 3 years as a U.S. Army Africa command surgeon from 2013-2016, and was right in the thick of this fight to find out how do we support small entities that are widely dispersed. And it is important to understand that if you're an 05 or below, or an E7 or below, you don't know anything in the Army other than the golden hour response that we had in OEF and OIF. You don't know anything other than regular ring flights between FOBs that have already been set up. You don't know anything really other than falling in on equipment that was left behind, because over time we didn't adapt to the environment in Afghanistan and Iraq. We adapted the environment. We changed it so that it met what we were accustomed to. We built big level 3 hospitals so that our providers could go to the same environment that they were used to training in. None of that exists in Africa. And so what we have is commanders as well that were accustomed to that golden hour response now being told, hey, there's nothing there. Now the interesting part is commanders are accustomed to balancing risk. They've just not had to balance that much medical risk in the past, but they're accustomed to balancing risk. Medical people try to mitigate risk to zero, right? And so that's often what stood in our way from saying, no, we can't do it, because our solution set was mitigated to zero. The new adaptation now in an area where there is no solid U.S. brick and mortar is small teams that are mobile. To wit, the extension of that we started in U.S. Army Africa under the guidance of then Major General Pat Donahue, now Lieutenant General Pat Donahue, the FORSCOM Deputy Commander, and then Major General Darrell Williams, was we said, look, why don't we find out what the operations guys are concerned about? What a novel idea, right? Don't think about, it's not about you, medical, right? It's operations only. Where are they interested at? And then how can you use what's there already to provide medical care? And at the same time, how can you use that as a training opportunity? So we started sending small groups of medical personnel, to include surgeons and anesthetists, in key locations based on the J3s and the G3s guidance to host nation military medical facilities. So the goal here is not to have to bring in a whole bunch of tentage, not to have to bring in a whole bunch of water, et cetera, but to use what already exists. Develop relationships locally there so that we could train in their environment. And when we go, we took no equipment whatsoever, because this allowed us to train our medical people to think austere. If you're only used to working in the best resource hospital in the world, when you're told on a moment's notice to go work out of a tent, you don't know how to do it. But if regularly you're working with host nation partners with the equipment that they have, and you build relationships, and General Ham, I know you know this, it's all about relationships. When you build those regular relationships, if you're working in that country regularly and something spins up, you've already got their brick and mortar building. You've already got their systems in place that you know how to use, and you've got the relationships that you can say, we need your help. And so you could use that platform as an intermediate place to push forward or casualties to and treat to then follow on care. So how is it adaptable? Imagine you take this 6 or 8 person medical team now, and they are regularly working at host nation facilities, developing relationships and enhancing their austere medical skills, right? General surgeons right now generally are doing a lot of surgeries with laparoscopic tools. We don't do laparoscopic surgery in wartime. It's all about the XLAP. So when you're in these host nation countries, you're doing that regularly, and then if needed, you can pull out at a moment's notice. That combination that we've been doing in U.S. Army Africa for the last 3 years, I think is a perfect model to go forward, to be mobile, agile, but directly support the warfighter. I think that is where we can get after our readiness training for our medical personnel. It's not just about surgeons, right? It's about getting the medics out there as well, because remember, it doesn't matter how good your surgical hospitals are, you can't fix dead. And so if the medic doesn't know what they're doing, we failed. So anyways, I would just say, in addition to the Surgeon General's push to develop these mobile surgical teams that can move on a moment's notice based on the warfighter's requirement, because the warfighter wants control. That's what they're accustomed to. If they are staged in the country then at places where they can maintain their austere surgical skills and then blow out as needed, I think that's a perfect model for readiness of the individual and then support to the operational environment.
Sir, can I please just do a follow-on comment to that? Because it is, Sergeant Major Eckert absolutely, Command Sergeant Major Eckert focused on it. It deserves a double tap. The medic and that response at the point of injury is the most important thing from my standpoint, from a tactical win, right, from reducing strategic risk, that is preventing death. That's the most important sweet spot that we have to focus on. We have done great things across the spectrum, but the reality is right now, if you look at all what we consider preventable deaths still on the battlefield, right now, fully 80% occur in the pre-hospital phase. That means before they ever get to the Role 2 surgical care. So we have done great work in our Role 2 and our Role 3, but remember, you can't fix dead. And so the work that's being done with the medics clearly needs to expand. And this team that's on board in the Surgeon General and Command Sergeant Major Eckert are after it. We need to think, and we need the civilian community as well, the civilian medical community, to help us get through that, because we are too handcuffed, quite frankly,
by the policies and licensure in the United States. Because what we're thinking about is ourselves and our financial concerns, and not costs in terms of human life on the battlefield. We need your help to figure out how we get these pre-hospital medics the best possible training when they're not at war. And that doesn't mean just taking vital signs, because they are the adaptable tool on the battlefield. When we talk about winning in a complex world, complex is defined as unknown, unknowable, and constantly changing. So you can't predict the future, you can only describe it. And this is what TRADOC tells us. The only way you win in an environment that is unknown, unknowable, and constantly changing is if your rate of adaptation is equal to or greater than the change that goes on around you. The most adaptable tool we have in our tool set is the soldier. So the focus needs to be on how do we train that soldier and get them comfortable adapting on the fly. And we need the civilian component's help to get after this problem. You are part of the nation's solution set here, and I personally need your help with that.